So good afternoon. For our last session this afternoon, I'd like to welcome Shannon Stacy. She's a genetic counselor with Seattle Children's Hospital, and she's going to talk with us about access to testing and issues surrounding reimbursement for tests that have been prescribed by your provider, just to give us some insight on how to navigate that process. So please help me welcome Shannon Stacy.
All right, as you guys get settled, Kim's going to be passing out a handout that I brought for you. It outlines a little bit about what I want to talk to you about today, the fun topic of insurance, billing, and reimbursement. So that's just a take-home for you. If you forget anything I said today, at least you have it there. And this handout was developed by Seattle Children's Hospital, so there are some specifics there, but overall it really translates to what you can take home, show your providers, and use yourself for getting insurance pre-authorization for genetic testing. So last but not least, I've been tasked with discussing with you the thrilling topic of insurance, billing, and reimbursement. A little bit of a background about me, why I'm talking about this here today, and kind of what I can share with you, what I've learned in my experiences. I'm a genetic counselor at Seattle Children's. I see patients part-time, but my main role is as a laboratory genetic counselor. And in that role, I'm able to review, it's the hot topic, or the word, it's called utilization management. So I review all genetic test orders that go out on our kids at Seattle Children's to make sure that they're getting the right test, the best test, and they're not paying for something that's not giving them any value. So there's actually 3 of us genetic counselors in the lab at Children's in this utilization management program, reviewing these test orders for all of our kids just to make sure that they're the right one. We educate providers on genetic tests, and the newest area that we're involved in now is insurance. So we're involved in Seattle Children's just issued a policy in 2012 that all genetic testing that goes out through Seattle Children's, so that we perform in-house, requires that pre-authorization. So we'll talk a little bit more about why that's important. So the outline today will be just a quick review of insurance plans, private versus state, what that might mean for you. Pre-authorization, what is it? Why are we going to do it? What do insurance companies actually look for when they're deciding whether or not they want to pay for that expensive genetic testing that your provider has recommended? We're going to review medical necessity, CPT codes, which is the insurance speak for billing for insurance. We'll talk a little bit about billing and reimbursement. What does covered actually mean? What is reimbursement? And what can I do? Really just to give you some ammunition to go home and to go to your providers and really help on this area. And I want to leave time for questions and stories. I think you guys are the experts, and I think I can certainly learn from you just as much as I can share what I know in this area. I'm also going to provide a few case examples of the genetic tests that we reviewed at Seattle Children's and how insurance has played a role in that. So briefly, the alphabet soup, HMO, PPO, EPO, what does this all mean? Large picture, you have your private and your group health insurance plans, either from your employer or personally. Examples are Blue Cross and Regents. Within these plans, they have their own health insurance plans that you can choose from. These are the HMOs, PPOs, and EPOs, and you might be very familiar with these terms, but if not, here's just a few examples. So a health maintenance organization basically is one of the most common ones. You have a primary care physician that coordinates all your care, but it has to be within that, with providers contracted with that HMO. A preferred participating provider organization is similar to that, except for you're encouraged to use preferred providers. You pay a lower cost option for those providers. You can go out of network. That's going to be more costly. An exclusive provider organization is just that. Your services are only covered if you're using those specialists. This really comes into play with genetic testing when a provider that's out of network is recommending testing for you, or you're getting testing done at an out-of-network hospital or lab. your insurance may or may not cover it, even if they have a genetic testing policy for the specific test. There's also the state and federal insurance plans, such as Medicare and Medicaid. Medicare, typically, they don't have a policy requiring insurance pre-authorization. Medicaid does most often. Sometimes they will reimburse testing, and most often, though, they do not. And we'll talk about different types of billing, institutional versus direct or third-party billing, and how these different types of insurance plans play into that. So this is done back in 2013, so slightly outdated, but still, Michael Graff is a genetic counselor at Evicor Health Plan, reviewed all publicly available data from the largest 200 payers to see who was listing their data about what genetic testing policies they had. And at that time, only 32% of payers had publicly at least one available genetic testing policy. So that's not, in my opinion, not a lot. That number certainly may have increased. There's significant variation among these policies, so some may cover testing and the other policy may not. They may have certain criteria, so it's really a little bit up in the air. Some plans really based it on evidence, but it was outdated. Genetics is growing faster than it's one of the fastest growing lab industries that there is right now, estimated to be in 2020 a $12 to $20 billion market. So testing is expensive, and the knowledge and the evidence that we have on why testing should be covered is slow to catch up to that process. Some tests had extreme variation in coverage. Examples were pharmacogenetics. Here's just a few common insurance plans. They're listed on that handout for you as well. It gets confusing often when I'm speaking with families about insurance and what it means. The process for them is at Seattle Children's, that we require genetic testing pre-authorization. So that means they come in to see the provider. The provider is recommending that testing. We recommend before they have their blood drawn that insurance pre-authorization is pursued. We do have a financial assistance program as well at Seattle Children's, so some families won't pay for the testing even if their insurance denies it, but many institutions are not that way. Families usually will get stuck with a bill if they haven't met their deductible, depending on their co-insurance or copay. And certainly their coverage may be higher or lower if they're in or out of network. And I'm sure these are things you are all familiar with after going through the genetic testing process for yourself or a family member. But these are just good to have in your back pocket to know what you're talking about, to have that ammunition when you need to have this conversation. So why do we do insurance pre-authorization, and why have we recommended it as a policy at Seattle Children's? So pre-authorization reduces the risk for both the patient, the family, as well as the hospital. So many institutions practice institutional billing. So if pre-authorization is not done, that insurance company may be less likely to pay for that testing. The family may be stuck with a small bill, but usually it's the hospital paying for that testing. And if they're not being reimbursed for it, it directly impacts their ability to care for other patients and to provide quality care for a longer period of time. So these are two of the reasons why insurance pre-authorization is very, very important. So what do insurance companies review in this process? Well, they do weigh evidence from published guidelines for medical professionals very heavily. So the National Cancer Societies, the American College of Medical Genetics, and certain other regulatory and governmental professional societies such as CAP, the Centers for Medicaid Services, FDA, and CLIA. So CLIA and CAP are laboratory regulating departments. They also review competitors' medical policies as well as certain patient advocacy groups' information as well. So as I mentioned earlier, genetic testing is one of the fastest growing fields in labs. The technology far exceeds the data that we have about evidence of utility and evidence that this testing is medically necessary for the patient. So oftentimes providers ordering a test that there's not enough data on, or there's no guidelines for why this testing should be paid for. And so that's a challenge. And we'll speak a little bit more about some other challenges. So successful pre-authorization does require medical necessity documentation. This should really be at the very, very beginning of that first submission for pre-authorization. And the provider and the family can participate in this process to make sure up front the insurance company is getting all of the information they need about why this testing is important for that particular patient. Here's these next two slides are examples of what should be included in that medical necessity language, whether it's a note or a peer-to-peer with that insurance company. You want to tell them the story after seeing the patient and getting a family history and looking through their medical records. What's the story that you see, and what condition maybe are you thinking about if it's genetic? So put that story together for them, and really make it individual for that patient and that family, not just a general, this is neurofibromatosis and you should cover it because. Technical and clinical validity, insurance companies are looking at very strongly, and even more so, which lab is doing the testing, and is this testing going to give us the answer that it's intended to do? Is there going to be a high yields if we send this testing for this methodology? For example, some conditions, the gene is going to have a higher detection rate if you start with sequencing. So these are the details that some insurance companies are getting savvy enough to ask for and to look at. Clinical utility, how is this going to change that particular patient's care right now? So if I do this testing and it's positive, I will do this, this, and this. I will give them a different medication, for example. Equally important is if we do this testing and it's negative, I won't have to do serial MRIs on this patient because I know that it's negative and they don't have this condition that I'm testing that would require that kind of testing. So negative and as well as positive outcomes of genetic testing are important to outline. Additional rationale, consider referencing any practice guidelines, but talking about the testing, and maybe it's not affecting this particular patient, but it's genetics as a family, involves multiple members of the family, and if you're testing one person, you're giving risk information for another. Sometimes this information can be helpful. So CPT codes are insurance speak. This, along with the ICD-9 or soon to be the ICD-10 diagnosis codes, are what insurance companies use to interpret that pre-authorization request or to interpret the bill that they get for that genetic testing. The problem is that CPT codes for genetic tests are still relatively non-specific, and this has evolved over time. In 2013, they became a little bit more specific, and now in 2015, there's actually new codes. For example, there's a brand new code for exome sequencing. Still doesn't mean it's going to be covered, but hopefully these will be added to the fee sheets for these insurance companies to pay for. This is an example. One of the codes, 81408, is the same CPT code used for NF1 as well as DMD. So the insurance companies just see this code, but it's not specific to what testing they're asking for. This is part of the reason why that medical necessity language is so important, and you're telling them what testing you want, where you're sending it, and why. Hopefully this will continue to improve each year. The molecular pathology, they come out with new codes, and the goal is to have them more specific. And the other problem is that new tests are outpacing these CPT codes. So there's one certain code that's used for tests that don't fall into any of these other categories, and they're broken down into Tier 1 codes, into Tier 2 codes. Tier 1 are more common, and Tier 2 are a little bit more complex and less common, but there's a code, a non-specific code, 81479, that falls into this bucket that is frequently not covered. But there are so many tests that fall under that code, which is why genetic testing is not being covered for that. So among the CPT coding issues, we have different issues when it comes to pre-authorization challenges. You order a test, your insurance says no, but you know that this testing is medically necessary, and it's confusing to you why your insurance company won't pay for it. They may have paid for somebody else, the similar test, there may be a different plan, but part of the challenges is the more advanced genetic testing gets, the less we're focusing on single genes. We heard from Denise and a few others earlier about exomes and whole genome sequencing and large panels. So an insurance company may look at it and say, well, I think this one gene in this panel is really important and medically necessary, but I'm not covering the cost of this whole panel because there's genes on here that have no evidence of medical utility. So they may cover a portion of the testing or none of the testing at all unless the request is modified. Another thing to mention about panels and exomes is More may not always be better. It may be a more cost-effective approach, but there is sometimes to pay for targeted testing, even if it's more expensive. There's an increased chance of getting variants identified when you're testing multiple genes at once, and sometimes that increases the cost for the family in the end by paying for follow-up testing on those uncertain test results. So as I mentioned earlier, recommendations from those professional societies are weighted very heavily, but because of all the advances, they're very slow to react to this information and publish those guidelines, leaving the insurance companies with not much to go on. So the typical response is this is investigational or research testing, which is a challenge for rare disease, particularly because most of the time the testing that's happening in rare disease is currently research, and so getting insurance to cover it is very challenging. Genetic testing is increasing so rapidly that there's 2 to 3 new tests a day, which that number was just very surprising to me. Lack of expertise and dedicated resources, there's not many involved in providing that information to the insurance companies. And payers just can't keep up with it. CMS and FDA, so CMS is the Center for Medicaid Services, and FDA approval does not automatically mean coverage from certain payers. So you may see that a test or the technology is FDA approved. That doesn't mean that your insurance is necessarily going to cover it. So billing and reimbursement. So authorization, you do the pre-authorization for the genetic test, and you get back this test is authorized, or my favorite one is no prior authorization required. That doesn't mean that they are going to pay for it, it just means they may or may not pay for it. And so you need to do more investigation about your specific plan and your company to see. Reimbursement is actually the level of payment, and coverage is just what that plan has agreed to cover within those benefits. So any payment of out-of-pocket depends on that specific insurance, your specific insurance plan, your deductible, your co-insurance, and your copay. Tests that are almost always reimbursed are examples of maternal serum screening, long-standing evidence that these change care for a particular patient, and cystic fibrosis carrier screening as well. Tests that are almost never reimbursed, which this is surprisingly few. As I mentioned earlier, there's sometimes seems to be no rhyme or reason what's covered and what's not covered. I've seen just the patients that I've reviewed at Seattle Children's, I've seen the same insurance company deny testing for one patient that was approved for another. Tests that are reimbursed when certain criteria are met. The common example is hereditary breast and ovarian cancer. So there's specific criteria that the insurance company has, and if they get a request for a particular patient, they cross off all those boxes to make sure that patient fits that bill. NIPT is also typically covered when certain criteria are met currently, and these do change over time based on new evidence. So this is just a schematic of the difference between institutional and third-party billing, and I don't know how many of you have heard any of those terms, but if you or your family goes to a hospital that participates in institutional billing, this means that you're going there, the provider at that institution recommends a certain genetic test for you. They do the insurance pre-authorization, they collect your blood, and they send it out to a lab that performs that testing if they don't do it in their lab. So they send it out to that lab. The lab will then bill the hospital, so this is the institutional billing part. The lab will bill the hospital bills the patient's insurance, and then the hospital is typically responsible for paying for the cost of the test back to the reference lab. The patient may get a bill, but it's typically just what their co-insurance or copay is. So this is what I was referring to earlier of when institutional billing is in place, hospitals end up paying for the cost of testing, which directly impacts the care of other patients that they're trying to take care of. Direct billing or third-party billing. The reference lab or the laboratory performing the test makes an agreement with the patient saying, this is your out-of-pocket, I won't charge you any more for this test than what we agree on at this moment, and I'll work with your insurance company to get coverage for it. But you're only going to see this amount of money on the bill. And then they bill the patient's insurance. The problems arise, institutional billing is certainly more flexible. Some hospitals have their own financial assistance programs. They also have documentation of that in their medical records, that this patient did do pre-authorization. They can help the patient cover costs of testing rather than some reference laboratory who promised that they wouldn't pay this much, but there's really no documentation for that family. So sometimes issues arise, which is why some hospitals will only practice institutional billing, so they have more control over what bill their patients see. And please stop me if there's any questions. Certainly want to make this interactive. So just a few case examples. This is insurance authorization was obtained as it was supposed to be to coordinate a testing for a patient with end-stage renal disease. So they went through the process, and this patient had a private insurance. So this testing at this time was close to $8,000 for this Alport syndrome panel. The testing, Aetna, the private insurance company, agreed to cover this testing, but they only covered it at a certain percentage. So after the hospital paid their percentage, the family or the patient is still left with a very, very large bill. So sometimes families are very confused when they get a bill when they thought that testing was covered or that their institution did pre-authorization for it and they said they were good to go. So these are things to keep in mind for yourselves and to family members to make sure you know what your out-of-pocket is and you know the lingo of the insurance company, what covered means and what reimbursement is and what authorization actually means. This is another case example. So this is a young girl who was admitted for vomiting, jaundice, and some elevated liver enzymes. There was a concern for a biliary obstruction or some possibly a genetic cause for her findings. So the provider had recommended testing for this gene that was associated with this condition they were looking for. So in the moment, they're ordering this testing. They think it's really important for this patient, and they think it's going to change medical care. As I said, the lab GCs at Children's, at least we review these test orders. We make sure that pre-authorization is in place for these families. The GC, the genetic counselor, checked in to see if the pre-auth had been done. By this time, the patient was actually in full recovery, and this testing wasn't necessary anymore. So this is a great example of when sometimes testing can be canceled or deferred and saving the patient lots of costs. So this is important for you to know, is to know what testing is being recommended for you and why. You or your child may be admitted or being seen a specialist, and they recommend testing. Because they recommend it, you go along with it. By having this institutional review process to make sure these steps are in place, we catch situations like these to make sure that you're not getting stuck with a bill for a test that was completely inappropriate in the first place. So this is what you can do, what I wanted you to take home from all of this, from this discussion. I know insurance isn't the best topic to talk about at 5 o'clock in the afternoon after a really long day. But it's really not to tell you, I don't work for an insurance company and I don't know all the details of each policy. But what I know is the current state, and it's evolving and it's changing and it's challenging because we don't have all the evidence that we need. And we don't have all the people to write down those guidelines for these companies. So it's evolving so quickly. So what can you do in this time to help get coverage for testing, no matter if it's a rare condition or something that's well known? Just understand what has been recommended and why. Is it necessary right now for my or my child's care? One of my favorite lines is, genetic testing is like a cell phone. It goes out of date every 2 years. Sure, you can order any testing that you want, but is it the right test? And are you going to find your answer for your family? Or do you want to wait and manage your care clinically if it's already being managed and see what's down the road to make sure you're getting the right thing? Call your insurance company. The handout that I provided you gives you a little bit of those guidelines of what to have written down before you do that. So things like the CPT code or the billing codes, and then the ICD-9 or 10 codes. The diagnosis code on hand. They're going to ask you for those. That's the language that they talk in. Questions to ask. So is this test covered by my specific insurance plan? Have I already met my deductible this year? And you may already know these details, but just to make sure you ask. Is the provider or hospital recommending this in-network? And that can be challenging when you're not really sure if the hospital or the lab is. But your insurance company can answer these and should answer these for you before you proceed with genetic testing. So also know about denial management. So insurance pre-auth, maybe it was done, maybe it wasn't, but you get a denial back from the insurance company saying we're not covering this testing. Know what your options are at that point. Is it just a dead end? Is this it? I can't get my testing covered. I'm going to have to pay for it out of pocket, or I'm going to need to look for other resources. Are there other options? Many insurance companies will either offer a provider appeal or basically a patient appeal. So the patient that has that insurance, they can appeal it themselves. Oftentimes we try to help our patients that are in this situation when it's a patient appeal process, giving those details that I provided you about what to include in the medical necessity language and telling them why this testing is going to change care and why it's needed for your family. Peer-to-peers often work very well, that I've seen in my experience. The provider makes a 15-minute phone call to that insurance company if they're offering this peer-to-peer service, saying, this is my patient's story, this is why I need this tested, these are the research that I found and the publications, you need to cover this testing. And I've seen many denials overturned by this process. So just because insurance denies testing, it's not necessarily a dead end for you. And include those letters of medical necessity. So just double check that this has been done. Ask your insurance company if there's an option to appeal. Ask your provider if they've been contacted about an option to appeal, and help them get that done, and they can help you as well. So here's just a few resources besides what I had handed out to you earlier. Each state has different plans. So Medicare and Medicaid, there's kind of a regulatory body, but each state has their own rules and regulations for Medicaid. So look at your insurance state's website. There's a genome.gov, which is very helpful. The specific one, most of them have been updated within the last 2 years, so they should be pretty up to date. Just as some information. It's challenging in the rare disease community for sure, because the evidence is a little bit more behind in the sense of getting published and providing specific recommendation and guidelines when you have a population of 1 or 2 or 5 patients with this condition. So that's why it is important, what we've been learning about this whole day is data, gathering data, getting the information and sharing it. This will certainly help insurance companies catch up with what they're recommending and what they're covering and denying. And I think that's all I had. Any questions?
I'm coming, on my way.
We get questions from our members who are interested in starting a family, and they would like to be screened if there is someone with our rare disease in the family, but they have not been diagnosed with the rare disease themselves. So they're very concerned, and do insurance companies assist in that at all?
For testing somebody that has a relative that has a genetic condition? That's a great question, and that's one of those, when we think about the criteria that they have for certain tests, that's one of the things some insurance companies will look at. Oftentimes, they know it's not recommended to test an unaffected family member for a condition, so they recommend testing that individual first. So they may come back saying, this individual needs to be tested, and at that point, we can cover testing. They may, if it's a rare condition, they may or may not, but I certainly have seen, why are you testing mom when the person that's affected in this family is the child? Sometimes it makes perfect sense to test parents first, but in a situation where you're testing an unaffected, insurance companies may or may not look at that as we need to start with the person that has the condition.
Well, what we're hearing is their decision whether or not to have children is based on that possibility, and they've been lucky in their family and they've had no symptoms, but there's a good chance they have
Right, that they may pass it on to their children.
Yes.
And certainly preconception counseling and genetic testing can be covered for those situations. It's really just dependent on the condition and it's how it's inherited and what the evidence is about making management decisions based on that information.
And who is our key contact to deal with that? An insurance company?
At the insurance company, well, you'll call your specific insurance company, their plan, and really you're going to want to get somebody on the phone that knows about their genetic testing policies. So that's the first question I would ask. And then I would have those details ready and handy, what testing you want, what the codes, because they might not even know what the test is without the code associated with it.
So as a patient group trying to help our members, we should get all the information together in a document and post it on our website, and that could help our members, correct?
It certainly could. If there's a test that's being recommended or that this is the testing that they should do, knowing what codes are associated with it is that information that they need.
It's just so complicated. Thank you so
Yeah,
much
it
for
really
the
is.
information.
Yeah.
Any other questions? Here we go.
Hi, so one of the questions that comes up in our foundation a lot is if children, like siblings or children of somebody that's already tested positive for their genetic mutation is tested, people are wondering if that hinders their chance for qualifying for health or life insurance down the road. Is there an answer to that, or is that kind of a still unknown area?
That's a great question. And so I get that a lot when I see families, and as far as I know, and the information that I have today is that, so there's, it's called GINA, Genetic Information Non-Discrimination Act, which was passed in 2008. That does not cover life and disability and long-term care insurance. In those situations, we recommend that that either be in place first, or the family contact that their specific life insurance plan to understand if they will deny or approve coverage. But GINA should cover health insurance. No discrimination is allowed for that. So that is in place. There are some loopholes, like I said, with life and disability. But that's a great question, and I would direct you towards the GINA website. They have a great handout that I give to all most of my patients who ask that question. It's a great handout.
Hi, Grace Whiting with the National Alliance for Caregiving. Thank you so much for your great presentation. Just this morning, we heard somebody say, you know, a lot of families rely on social media to share information, and that's not, it's both a good thing that we have social media, but also a failure of the healthcare system to put these infrastructures into place. And so one thing that strikes me during your presentation is how difficult it is to navigate as a patient or as a caregiver or an advocate for that patient. So I'm wondering what your thoughts are on what the big system changes would be. If you had a magic wand and you could create a federal policy or a model law, what would that look like?
Gosh, I mean, actually sitting right behind you is a genetic counselor who's gone straight to the insurance companies. Jody, I'm going to call you out now. She's gone straight to the insurance companies to explain why they need to be covering this testing. And honestly, my magic wand would be to create more of Jody's. And at institutions to have laboratory genetic counselors or genetic counselors fighting for their patients at that hospital to be able to navigate this difficult system, and then eventually have policies to cover certain genetic testing. Just more information. That's kind of what I would say. And Jody, if you want to respond.
I would say the only thing I would add is policies. I mean, I think that when an insurance company doesn't have a policy in place, each individual decision is a case-by-case decision made by the medical director that's reviewing the case. Mm-hmm. And so it leaves a little bit of room for subjective decisions. And so I think policies are important, but having the data to create policies and the time for a policy for every genetic condition would just, it would be huge. So I think that having some centralized policies for genetic testing is like a big system change that could make a big difference. And there are some companies that are working to try to create that.
There are, yeah. Thanks, Jody.
Are there any other questions? Oh, here we go.
Hi, I'm Andra with Lipodystrophy United, and the community that I represent has a lot of external physical manifestations of the disease in addition to internal. So a big question to the foundation all the time is, how do you get some of the cosmetic aspects of the disease covered? And we have patients who've had it covered, and we've had patients who've had no success. So what's your advice to me as a resource?
That's a challenging question, and it comes up with several different conditions. Another common one is Treacher-Collins, where really most of the medical testing or medical management that they're getting is considered cosmetic. I think that's really going back to the case-by-case. This is why this is important for this patient. The whole what is medical necessity and what's going to change medical management for a patient is a difficult, it's much debated, because for one person it's medically necessary because this is changing their quality of life. This cosmetic surgery is really giving them a better outcome on their life and their family's life. So those details, I think, to include in those case-by-case stories and setting the stage for the insurance company to look at it, that's really the only advice I can give. There's no magic code to what to say. I think it really is this is how it's going to improve this patient's health care. And really, insurance companies look to save money. So they're looking to say, how is this test later down the road going to save me from having to pay more money for this patient? And so that's one of the challenges, certainly, that's faced when you're asking them to pay for what they consider as cosmetic. But I would give them that information of how it may change your care in that way, in terms of quality of life. Is that helpful, I hope?
Any other questions? Okay, thank you.
Yeah, I know we're ending a little bit early, but thank you so much for listening, and I'm happy to talk afterwards as well.